Welcome to Black Health Matters. I'm your host, Darryl Armistead. This is a Howard University Hospital transplant support group session led by Dr. Clive Callender, who is a noted transplant surgeon and professor of surgery at Howard University College of Medicine. Let's join today's session in progress.
Who has been on our program more than any other person. She has always agreed to present to us on the urological problems of men and women who are above 50. And so today we are very fortunate to have Professor Pamela Coleman, has so many titles. I won't even bother to talk about them because she's also president of the Howard University staff as well as many other titles. But one of the things that she has done for decades now is talk about the urological problems that occur to men and women as they age. And so today we're blessed to have her to talk to us about what we can do to help ourselves as we age and as urological systems tend to age along with us. So it's up to you, Dr. Coleman. You can take it from here.
Okay, thank you very much, Dr. Callender, and welcome everyone. Now let me make sure you can see my slides. Are you able to see them?
Not yet.
Okay.
Did you press share at the bottom of the screen?
Yeah. Okay, let me go back to our Zoom. You still don't see them, I guess.
Not yet.
Okay. Yeah, sometimes this is a challenge.
Do you see the share button at the bottom of your?
Yeah, I do. Hold on. Oh, sorry. All right. Let me just go so we can. Sometimes in my office, there's an issue with this. So let me just check something here. Give me 5 minutes. I'll be right back.
Okie dokie.
Okay.
Well, we know that she's on the internet. That's part of it's working good.
Yeah.
Her picture and all that came out. Her sound is working pretty good. Uh, uh, if we can go back, focus back on that share button, there's a little few more steps you have to take after you share. A couple other things you have to do.
Yeah, she has to click on the presentation.
Oh, yeah.
So the host has the host enabled me to share.
You can share.
Okay, now try it now.
Okay, so which screens are you want to show? This PowerPoint. Where's my PowerPoint?
Yeah, we did have that disconnected for a second. Sorry about that.
PowerPoint. Urologic PowerPoint. Yeah. No, not that one. Sorry. Golden, oh, go back. I should see golden needles. Golden needles. Okay. You're almost there.
John, let me ask you a question.
Mhm.
Did you?
There we go. She's good now.
Okay, is she
Okay, can you see it now?
Yes, ma'am.
Okay, great. Thank you.
In good shape.
Okay, we're in good shape. Let's get started. Sorry about technical issues. Okay, so everyone seeing and hearing?
Yeah.
Yes.
Great, thank you. So I guess the first, obvious question is why urological health matters. And I think you guys are really, really up on this, but urinary system is essential for maintaining good health and comfort. Especially after transplant, particularly your kidneys and bladder, they deserve some extra attention. So my goals for today is for us to understand some common urologic problems in our golden years and learn ways to prevent and detect them early. So let's start off first, how aging affects the urinary system. Well, the bladder becomes less stretchy, so it holds less urine. The prostate, of course, which is only found in men, often enlarges, slowing the urinary stream and flow. There are also hormonal changes that can weaken our bladder control. In men, particularly lower testosterone levels, and in women, lower estrogen levels, which affect the vaginal health in terms of reducing urinary tract infections and being continent. The nervous system also is important. Our nervous system, the sensation that our bladder normally can feel and let us know when we feel like we have to urinate, may be decreased. So why are transplant patients at a higher risk? Well, some of this, you may be on immunosuppressants, and these immunosuppressants can increase your risk of infection and also can affect your kidney function. You may be admitted into the hospital, have a catheter placed. A catheter or hospital stays can also introduce bacteria. And fluid restriction or dehydration can put a strain on the kidneys and weaken them over time. Some of the common urologic concerns in our golden years are the following. I'm sure you've heard of BPH or prostatic hyperplasia. Again, the prostate only found in men. Overactive bladder. Overactive bladder is something that I'll talk about that can occur in both men and women, and it increases as we age. The bladder becomes less compliant, it's less likely to hold urine, or it holds too much urine. Urinary incontinence. Urinary incontinence is the loss of urine, an involuntary loss. We don't have any control over that. It may come as an urgency or a gotta go sort of type sensation, or a laugh or a cough or a sneeze and a loss of urine, or a combination of both. And believe it or not, this can be seen again in both men and women, more commonly in women after childbirth or even after one child or multiple children or pelvic surgeries, and then also in men after pelvic surgeries, particularly prostate procedures, prostatectomies. And then we have recurrent urinary tract infections. Recurrent urinary tract infections, I'll speak about, may or may not be the usual sort of burning with urination, but just a low-grade fever. Bladder retention or incomplete bladder emptying, again, can affect us in our golden years. The bladder doesn't empty as well as it used to. It's like a pitcher full of water that as you drain that pitcher or pour it into a cup, you're emptying less and less each time. So to empty that entire pitcher, you've got to go more times, or maybe you don't go at all, and you have what's called overflow incontinence. So the pitcher is full of fluid, and as it fills up, as the bladder fills up, it doesn't empty well. So it just overflows off the top, and then urine just leaks. Not really a normal voiding sensation, but a leaking of the bladder. So let's look at the urinary tract infections. The maybe common warning sign I usually tell my students is the burning or dysuria with urination. So this is a burning or discomfort as the urine is passing through the urethra. Sometimes there can be burning or discomfort just in the suprapubic area, but you just palpate below your belly button in that area above your pubic bone, there may be discomfort. Or there may be discomfort after urination, particularly in women, where the acidic urine touches the vagina, and if there are any open lesions, may cause discomfort. The urine can have a cloudy or foul smell. Now, this is not always necessary for a urinary tract infection. Certainly, we all know if we eat certain food, asparagus, broccoli, beets, things like that, and we have the holiday seasons coming, there may be a distinct smell to the urine. Usually we don't smell the urine because when we urinate to the toilet, it sort of gets dissolved in with the water and the fluid. But urine is by itself, if you would, to just put it in a cup by itself, would have sort of an alkaline smell. So this may or may not be a symptom, but if you notice there's a change in the smell of your urine, it could be a sign of a urinary tract infection. Fever, chills, or back pain, even the lowest grade fever. A lot of times patients will come in the hospital with a fever, and the one thing that really needs to be ruled out besides other conditions is the urinary tract infection. Feeling weak or confused. If you have loved ones that live at home with you and you notice a change in their mental status, or if someone notices a change in your mental status, this sometimes can be a sign of a urinary tract infection. So some of the preventative tips might be drinking plenty of water unless you have a fluid restriction, and emptying the bladder often so that bacteria does not accumulate in the bladder and then is able to grow in that medium and cause a urinary tract infection. Overactive bladder and incontinence. So the most first common symptom of overactive bladder is urgency. Now, urgency is more than just the desire to urinate. We all, sometimes you may be sitting here now having desire to go, but you're able to hold your urine. But it's an overwhelming urge to go that you can't hold back. Sometimes you actually may leak urine, or you may have a sensation that you're going to and not leak, but you feel you've got to go, putting the key in the door and you've got to go, you've got to get there. Frequent urination. Well, what's considered frequent urination? In adults, if you're drinking adequate amount of water, you should urinate about 6 to 8 times a day and not get up more than twice at night. So sometimes if you are going on, let's say you're starting a diet and you're increasing your water intake or fluid intake, well, you might start going to the bathroom more frequently than usual. So keep that in mind. But nighttime trips should not be more than twice a night. We'll give you a little bit of leverage there. And then leakage, as I have spoken about urinary leakage, either urgency or stress urinary incontinence. What are some tips that we can use here? Well, bladder training. Timing our visits to the bathroom. Now, what I will say about this is that when you drink fluids, you shouldn't just sort of like have a container there or glass and you're just sipping water all day. That doesn't give your bladder a chance to really fill up and empty. So if you're going to drink fluids, which we all should, you should drink them at a controlled time. Let's say you drink a bottle of water, and then you want a time that you're going to go to the bathroom within 1 to 2 hours. Or you may want to prompt yourself to make sure. So if your bladder tends to hold more, you might want to set your watch and say, I'm going to train my bladder to go like maybe once an hour or twice an hour, but you really don't want to hold it more than 2 or 3 times, 2 or 3 hours before you go. The other thing is there are certain bladder irritants like caffeine and alcohol that can just in themselves irritate the bladder and make you feel like you have to go to the bathroom. In this, I would also add to this acidic fluids also can cause the bladder irritant. So try to avoid these, particularly at bedtime, maybe about 4 hours before you go to bed, so you don't feel the need to have to go as often. Other tips, use of pelvic floor exercises. Now, men and women can both learn how to do pelvic floor exercises. The pelvic floor, you can think of it, we used to say the sacral nerves should be in forward, keep the bladder off the floor. But basically those, when you think about it, if you're going to pass gas and you're in a place and you don't want to pass gas and you tighten those muscles, you're starting to use those pelvic floor muscles. And when you do these type of exercises after Dr. Kegel, that's how they got this name back in the 40s, he first introduced them. So they're called Kegel exercises. When you're starting to work on these muscles, you can actually have a physical therapist help. And a physical therapist can help with bladder training. You can ask your doctor for a referral. And when you see the physical therapist, sometimes they may put a small probe either in the vagina for women or around the anal area, and they can actually see when you feel like you are contracting the right pelvic floor muscles. So it's not just a matter of moving your legs in and out, which is working on your muscles of your thigh or inner thighs, but actually working those muscles that are inside, thinking about. And you can do these exercises even like sitting here now, toning those muscles. And then there are medications. There are safe medications that you can discuss with your doctor, particularly as myself as a urologist or a urogynecologist, even a primary care physician, that can help with overactive bladder and bladder control. But I would just caution to say, if you have these symptoms, see your physician and make sure first you don't have a urinary tract infection, something that can be treated with an appropriate antibiotic. And don't just put a Band-Aid on the area. Some people will run and get a Depends, which I think is just a huge Band-Aid that masks your symptoms, but actually go and figure out what's going on and get a diagnosis. Prostate health for men. BPH, or benign prostatic hyperplasia, is very common with aging. The prostate, as you know, sits right outside the bladder and surrounds the urine tube of the urethra. So it doesn't necessarily have to be enlarged, but its effect on the bladder can cause change in the urinary stream, or its effect surrounding the urethra can also change the urinary stream. Prostate cancer. As I have given this talk to students before several years ago, prostate cancer is considered having the PSA, prostate-specific antigen, which is an enzyme made by the prostate in both benign conditions and malignant conditions, and the digital rectal examination. As time has gone on, and it's really interesting, I still do digital rectal exam on my patients, but unfortunately, as some of the teaching has gone on, prostate cancer screening now can be done with just doing the PSA alone. The PSA should be less than 4 as you age. But in younger men, though, I'd say less than 40, 45, 50, the PSA should be less than 2.4. But this can be certainly an early screening test to look for prostate cancer. And I do feel that the digital rectal examination does hold value in terms of giving an idea on the size of the prostate, if there's anything abnormal felt in the prostate. And I will say that not all prostate malignancies cause an increase in the PSA blood test. So the two of these together, I think, are very helpful, but certainly just having the PSA is important. And your primary care doctor can do this when you get your cholesterol checked or your blood sugar checked. It's a blood test, and they can sort of fill that in with your panel, and we can use that for screening. When do we screen? That's another question. But screening, I will say, should be done in men over 40 and those who have a risk factor. Risk factor first is being Black, ethnicity, second, family history of prostate cancer, especially someone in your family that had their prostate cancer early. And so this will be a reason for screening. How long do we screen? Again, another area of concern, but in general, the United States Preventive Services Task Force should say that you should have a shared decision making discussion with your physician, but certainly between 40 to 74. I would say that we are living longer, and so we do look at your 10-year life expectancy. So having a 10-year life expectancy, if you're 74, you're in good shape, playing golf, enjoying life, I would still increase screening. Now, screening, again, is just looking for cancer. If you have signs and symptoms, if you see blood in your urine or semen, pain with urination or ejaculation, trouble starting or stopping your urine flow, these are symptoms more commonly of BPH, but also can be seen other prostate disorders. So at this point, we're not actually screening, we're actually looking to make a diagnosis. And at that point, then a PSA and a digital rectal examination are important to do those things. Your kidney function blood tests are important. The creatinine, which is a test that can be measured in the blood and the urine, this is a good idea of kidney function. High levels usually mean that there's slower filtering of the kidneys. They're not working as properly as they should be. Your GFR, or you might think of as the grade of your kidney health. You may have been told, oh, you have a GFR, a certain number. It's different in men and women. And it's interesting, this difference also in African-American people as different and Caucasians. And there is some controversy with this and research being involved, but right now the standards are there and what we're looking for. Protein in the urine, this can be a very, very early sign. When you have a urinalysis, you should not have any protein, whether it be trace or higher in the urine at all. It can be a sign of early stress on the kidneys and damage to the kidneys. So as most of you know, understand and ask your transplant team for your latest results. Make sure that you understand them, you know what they mean, and if you need further consultation, hopefully they will provide that for you. Sexual health after transplant, very important in terms of our quality of life. But some of the common issues that we might see might be a low desire for sexual activity, maybe fatigue, not having the strain muscle, maybe used to walk a mile a day, or some people I know even walk 5 miles a day, or whatever you're, you might say, I need 10,000 steps a day. There may be, again, as I mentioned earlier, hormonal changes, lowering of the testosterone, which we do see as with aging, but there are significant numbers that we'd like to look at. In women, changes in the estrogen levels, and sometimes, and this can be replaced safely to the vaginal area with estrogen cream or Permanent vaginal cream, estrogen tablets, or a ring that's placed in the vagina that has estrogen in it, and it's just changed every 3 months or so as needed. But this estrogen that's given back to the vaginal area, though, is only absorbed in the vagina. It does not have systemic absorption, nothing at least significant. However, if you do have a history of breast cancer, you might want to have an oncology consultation just to make sure. But it will provide estrogen to the vaginal areas in terms of vaginal dryness. There are certainly medications that are given that can affect sexual health in general, particularly blood pressure medications. As I mentioned, just age in general. Certainly amount of anxiety that can affect sexual performance in general, maybe is a discussion with you and your partner and others, and overall illnesses that occur as we get older that affect our sexual health. So keep in mind, though, that safe treatments are available. And what you should remember, don't hesitate to ask. If your physician may or may not be qualified to discuss this, ask for a referral to someone that you can discuss with and that you will feel comfortable discussing safe treatments for sexual health. Cancer awareness. Well, certainly if you see blood or anything that looks like a discoloration of your urine, that's something to watch for, and to head straight for it to your primary care doctor or your healthcare provider. Weight loss and fatigue, again, as I've mentioned, any changes in your usual daily habits, maybe something that may be a sign of particular cancer or something abnormal that's going on. Persistent pain or urinary changes. If you maybe go out and have a good dinner, maybe something to drink, alcohol in the evening, that may get you up at night. But if these symptoms persist, then seek attention. Always keep in mind that early detection gives us better outcome. Lifestyle and prevention tips. Drink an adequate amount of water. Well, what would be considered adequate? And sometimes some of you may be on fluid restrictions, but in general, if you take your weight and divide it by 20, so 120 pounds divided by 20 is 6. So at least 6 glasses of water a day will be considered an adequate amount of fluid. Certainly, if any of you are out there going to be running the Marine Corps Marathon this weekend, you're going to want to be drinking a bit more fluid, or if you're walking it or doing other activities, you have to keep that in mind. Limit your caffeine intake. Certainly, hopefully no one is smoking. And alcohol restriction. Doesn't mean that you can't have an occasional adult beverage, but you want to keep in mind that it can affect the bladder, and you want to limit urine and not overindulge, especially as we go into the holidays, of course. Eat a balanced, low-salt diet. Balanced. What, again, some of these words you say, well, what does that mean? How does that mean? If you need help, there are nutritionists that are out there. You can keep a log of what you eat, and then you can look at it, discuss it with your physician. In general, a low salt diet is probably best for most African Americans. A salt is something that, of course, is going to sometimes retain fluid. It can be a problem in terms of swelling in our bodies, around our heart, in areas that we're not even aware of that we can see. But again, you want to have a healthy amount of salt in your diet too. You don't want to have such a low salt diet that you're hyponatremic and it affects your mental status and your overall well-being. And stay active. What you're doing, whatever that is, get a consultation if you need to with a primary care doctor or cardiologist. Make sure your heart is also healthy. And as you know, get regular checkups to make sure things are fine. You can even check things up yourself at home. You might have your own blood pressure monitor that you use. You can check in the morning and the evenings. You might have a urine. There's actually dipsticks that you can buy over the counter that can give you an idea of a change in the color of the urination, which may point to possibility of a urinary tract infection. These all things over the counter that can be bought through Amazon. And there's some other things that you can do yourself at home and then follow up with your primary care physician. When to call your doctor? Any pain out of sorts that you've had. Burning was mentioned before for urinary tract infection, and certainly gross blood in the urine. Sometimes there is blood in the urine that you don't see with your naked eye. And so that's why it's helpful when you do your primary care evaluation and your overall physical blood tests and urine tests. If there is found to be microscopic blood in the urine, blood that you can't see with the naked eye, your doctor should refer you for further consultation. And I will say this is very important, particularly we have seen recently in women with recurrent urinary tract infections not getting referred in a timely fashion. And then sometimes, unfortunately, when they do come to have a bladder tumor and a bladder cancer, they're diagnosed at a later stage than they should be. There are new tests that we can do now besides just the urinalysis. The urine cytology is really only helpful if it's positive. If it's negative, it doesn't mean that you don't have an abnormality in your urinary tract. But we can do a cystoscopy. I don't know if any of you have had a cystoscopy, but it's putting a scope inside the bladder and looking at the bladder wall. Usually that's done with what's called white light cystoscopy, but now there's also something called blue light cystoscopy, with putting a particular chemical into the bladder that just gets absorbed in the bladder cells. If there are abnormal cells in the bladder, those cells, the hemoglobin in those cells will absorb the cystobute chemical and will turn a pinkish reddish color. So when we do a blue light cystoscopy, we can look in your bladder and see if we see this discoloration. And if so, it might give us an idea that that area needs to be biopsied or that area is a possible area of malignancy. And so it can further add to our detection of abnormalities in the bladder, bladder tumor, bladder cancer with the blue light cystoscopy versus the usual white light cystoscopy. As I've mentioned before, fever or chills, even the mildest change in your body temperature may signal that you need to speak with your physician or go to the emergency room. Trouble emptying the bladder, or again, any swelling or fatigue, or decrease in your amount of urine. So quick communication helps to protect not only your transplant, but of course your life and your health in general. So finally, I would say that there are a lot of resources, as you know, here at Howard and support. This is my number directly to Howard University Hospital Urology Department. I know sometimes you may call and can't get through, and you're certainly welcome to call me personally or our insight number to our urology. We're actually a division, not necessarily under general surgery, to be seen and evaluated. Transplant, you have your transplant clinic contact, and there's certainly a educational resource available at Howard. I will say one that I'm director with is called the Men Take 10, which is take 10 minutes to make sure you have good prostate health. We offer free PSA and prostate cancer screenings. So take advantage of those things. Finally, your bladder, your prostate, kidneys are part of your success story. So let's keep them healthy. The latest African American proverb, and I actually saw this when I went to the African American Museum here in DC, which if you haven't gone, I encourage you to go before changes take place. But there is a slogan, lift as you climb. So bring another one with you, each one teach one. You all have a very good idea of this and talk about this maybe in the barbershop talk as we speak, or whatever with your friends playing cards or partnership or whatever, so that we can have a healthy life. So thank you for your time and your partnership in health. I'll take any questions.
Thank you so much, Dr. Coleman. Very timely presentation for all of us. And so John Buchanan has his hand raised. You want to?
Yes. Mhm.
Dr. Coleman, thank you so much. It was excellent for me. I think that maybe somebody is not muted and they're feeding into the audio. But anyway, I had several questions. One, you mentioned incontinence. So is there such a thing as continence?
Continence, yes. So continence is what when you do have your bladder control, you're able to tell yourself when you feel like you'll get the sensation that you want to urinate. Most of the time we can kind of inhibit that for a while, for a bit, and then when we actually then want to go to the bathroom, so then we are continent. But incontinence is that we don't have that voluntary control over our bladder, and we leak urine when we don't want to. When we're not in the bathroom, we're not ready to use the toilet at that time.
So if that starts to happen, where you may be headed to the bathroom but can't really make it all the way, what should you do?
Well, what you should do if that starts to happen to you is to take note of when it's happening. And then if it continues, you should really see a healthcare provider. And for some people, that can just start with your primary care physician, letting them know what's going on, getting a overall physical examination and the laboratory tests that are needed. So that is, when these things happen, they are warning signs that our body is not performing as it should be. So now you may, initially say, well, let me go and get the type of undergarment to kind of protect myself so I won't be embarrassed. That's fine. But don't continue with that. Go and get an evaluation, and so that you can see. Sometimes it could be, just like I said, a urinary tract infection. Sometimes it could be maybe a sign of new diabetes or glucose or some irritant in the urine that's causing that. But the main thing I want to stress is to be evaluated. Don't just try to protect yourself with a depends. Don't depend on the depends.
Okay, and I actually have two more. So I've been on the BPH medication with tamsulosin for several years now. And you mentioned not getting up more than twice a night to go to the bathroom. I don't know. Before this, I never woke up to go to the bathroom. Now I usually do, but just once a night. So that's okay, you think? Just once a night is all right.
Yes, once a night is all right. Again, if you want to be sure, just see your physician, get a quick urinalysis done. But if that's sort of like a change, like you said, you've been on tamsulosin, which is the generic name for Flomax. Some people may know that as Flomax. That's the brand name, which helps with BPH in terms of allowing the bladder to empty better. It's what we call an alpha blocker. And you've been on that for years. So maybe if you can stay on that, if that's good, or maybe you need to come off of it at this point in time. I don't know. Some medications do outwear themselves, but But if it's a change that you're getting up now once a night, look first at what you had to eat or drink before you went to bed that night. Did you eat or drink late? Was it something that was coffee, caffeine, tea, chocolate actually has caffeine in, other types of things? Keep that in mind. But certainly if it's a concern to you, have it checked out. I will say, as I mentioned earlier, the bladder becomes less compliant. It doesn't hold as much as it used to. And so for seniors, we'll say once or twice a night is probably within acceptable range. But if it's something that is a change, then have it checked out.
And my last question, thank you so much for what you said so far. Every commercial on the sports network has to do with testosterone boosters. Can you talk more about that? Are those things necessary? Do they really work?
Yeah, so first thing I will say with commercials in general, and when they are talking about medications, remember that I think they usually say now that this product is not intended to diagnose, treat, or do any of the above. So keep that in mind. And so is the product that's being sold over the counter. And usually the amount of testosterone that is in that product is really not enough to help with a lot of things. Most of the time it's a placebo effect that when you take it over time, you think it's helping, but eventually doesn't. But again, testosterone is a hormone. It's made by actually women and men, but higher in men. And it's really more related to your libido or your sex drive. But it should be checked. It should not be used without knowing what your testosterone blood level is. And I would say that the blood test, usually we like to do it in the morning before noon, because your testosterone has a circadian rhythm. It's higher in the morning and lower in the afternoon. So check that out, get a check for that. It has a wide range from 200 to 1100. 1100 range when you're in puberty, 200 range as you get older. So, and then sometimes we even want testosterone levels to be lower, because testosterone in its most active form is something that is helpful in prostate growth of normal cells, but also in cancer cells. So for cancer cells, we like to restrict testosterone to those cancer cells, so it's not feeding those cells to have them grow. So I would say, if you're someone who has prostate cancer, especially if you're in the early stages of treatment or you're in radiation treatment or something, you do not want to go out and get over-the-counter testosterone medication and start treating yourself because you think you have, quote, low T. Make sure that you, again, have evaluation with your physician or urologist regarding that. When we do, I will tell you, testosterone, when we do prescribe testosterone, is one that actually requires a prescription. It's not really a medication that you can go and buy over the counter like Tylenol or something. I mean, actually, if you look at aspirin nowadays, probably if it were to come out now, would require a prescription, because it does so many things. I mean, the headaches, blood thinner, this, that, and everything else. So, but in the dose that you can get over the counter, unless you abuse that, shouldn't cause you any problems. So testosterone is not a benign medication or chemical to put in our bodies. It also, another thing I'll just mention, that in sports, as you mentioned, when people go and take exogenous or outside testosterone, the body actually sees it. Oh, I'm getting extra testosterone, so let me lower my own testosterone. And so it lowers your own testosterone. And so in doing so, you don't have it available for your overall health. And so we see sometimes in some men, particularly sport, for example, those who are boxers or cyclists or people, and they lower their own endogenous testosterone, they have side effects or complications from that. So it's not, low T is not to be taken lightly. Again, it's something that requires evaluation. And I will just mention one other factor since you brought it up, testosterone health in terms of diabetes and high blood sugar. There is a sort of relationship there. So occasionally, and people that are diabetic, when monitoring their hemoglobin and A1C, your endocrinologist may also look at your testosterone levels. and see what those are. So the commercials are there selling a product, but remember, they're not there to diagnose, treat, or enhance any particular condition. Make sure you get evaluated appropriately.
Thank you so much.
Thank you.
Darryl Armistead.
Dr. Coleman, thank you so much for an excellent presentation. Is sitting down to urinate more effective in emptying the bladder than standing up for men?
Okay. Thank you for that question. So in men in general, you should stand to urinate. When you sit down to urinate or feel the need to sit down to urinate, it's a way that you're putting a little bit more pressure on the bladder to empty your bladder. So it in general can be an early sign of perhaps BPH, for one thing, enlargement of the prostate or the prostate effect on the bladder opening. It does allow you to empty your bladder better, but it's not the normal way that you should empty your bladder as a man. You should be able to stand and empty your bladder appropriately. There also may be a few drops of urine, as you know, that may come out after you urinate. But if you have significant, like if you leave the bathroom and then you're still having urine leaking out after you've left the bathroom, what we term as post-void dribbling, so after urination, urine dribbling, that also may be a sign of BPH, and that needs to be evaluated appropriately. So sitting down, now I will say that for some people, some men do need to sit down to urinate because they've had prior surgery or other things that have gone on. And so that can be an effective way to empty the bladder, but that is not the normal way that you should empty your bladder as a male. Women, yes, we do sit down to urinate. We have a shorter urethra, and so it's shorter tube to urinate through. And so we do, learn to sit down to urinate to empty our bladder. The other thing is that you should not have to press on your bladder to urinate. When you feel the need that your bladder is full and that you have to urinate and you get that desire to go, and then you decide to actually go to the bathroom and urinate, you should not have to press. Pressing on your bladder is a maneuver called the Crede maneuver. We used to teach that particularly to children in the pediatric age group to help empty the bladder. But what you're doing when you're pressing on your bladder, yes, you're putting a increased force on the bladder, which normally is going to bypass your urethra sphincter and then for the urine to come out. But you're also putting force on the bladder that can cause the urine to back up and go back up into the kidneys. And even sterile urine that backs up into the kidneys can cause kidney damage. The normal boarding pattern or when we urinate is that we get the desire to go, we go to the bathroom. What first happens is that the resistance in the urethra has to lower, so the urethra has to open up, and then the bladder muscle, as a smooth muscle, contracts and the urine comes through. If those are not coordinated like that, what's called dysynergia or uncoordinated movements, they can over time cause injury to the bladder and also backup injury to your kidneys.
How many accidents should you have to have before you see a urologist? For example, depends is something that is available now. So if people have an accident or two, should they see a urologist after a single incident, or what number of incidents do you think is necessary before you should see a urologist if you have that kind of urinary incontinence?
Yes, thank you for that. Well, one I would say is too many. And if you have one, there's too many, especially you're out at that gala and you have that accident, right? You've got your special tux or dress on. But occasionally, you can have one accident for different reasons. Maybe you overdrank, maybe you overfilled your bladder, maybe you waited too long, to get to the bathroom, whatever that may be. But if it's persistent, then you should have evaluation. It should be checked out. If it's something that is of a discomfort to you or something that you find that distressing, you should have an evaluation. So one accident in general probably is something that may happen to all of us at some point in time, but if it's persistent and if it bothers you, then it should be checked out.
There was a recent article that talked about the fact that prostate cancer in men is being diagnosed at a later stage than it was before. It was one of the opinions was that this was related to the fact that there was a time about 3 or 4 years ago when they said that PSAs were unhelpful and they should stop screening. Uh, what is your position relative to the advisability of getting PSAs for people of color, as particularly men of color?
Yes. So the PSA blood test became available, and it's a great screening test for looking for prostate cancer. What happened, I think, as I know, actually, a couple of years ago, once the PSA became available, people were drawing the PSA on everyone, and there was no real true recommendations on who should get a PSA and who should not get a PSA, which then led to patients being referred to urologists, which then led to biopsies. And so prostate biopsies were done at that time most commonly transrectally. As we know, the rectum holds a lot of its own bacteria, which if they're there, they don't cause an issue. But once you introduce a needle through the rectum into the prostate to get a biopsy sample, you potentially introduce bacteria and infection. And so people were, a higher number of people were dying from bacterial infections after transrectal biopsies. So the United States Preventative Services Task Force looked into this and did studies and decided, well, we are doing too many prostate biopsies that are not needed to be done. And I will say the cohort that was studied was white men in Europe. And so the recommendations that came out then was to stop doing so many PSA tests for screening. So this would lower transrectal prostate biopsies, which would hopefully then lower the risk of infection, because one can certainly die from urinary tract sepsis after a prostate biopsy. So, but the cohort that was studied was not in people of color, and so therefore there was a great upswelling from people of color, different organizations that said, we Black men are dying. People of color are dying from prostate cancer, particularly African-American men. And we need to do this prostate screening, and we should look more intelligently at this and not just come up with a blanket statement, not to screen, not to use PSA screening anymore. And so the recommendation initially for PSA screening, without this was like they graded as an F. So they now said, well, okay, we'll allow you to screen in high-risk populations after shared decision-making with your urologist or your physician. And so it changed. The recommendations changed that it should be in men. And I say that because we have transgender females. We don't take the prostate out of people when they decide to change their gender identification. And so I do have men that are transgender females that have had prostate cancer because they still have their prostate. So the recommendations are that you still need to have a discussion with your physician and look at the people who are in a high-risk category. So high-risk category are people of color, people who have, like I said, family history of prostate cancer. And so the recommendations have shifted now. They are, if you look at, they are a grade D recommendation, not an F like they used to be. PSA screening should be done in that risk population. And with doing so, we have seen a shift in terms of diagnosing prostate cancer early. I would say even with our Men Take 10 center, we've always done prostate cancer screening at Howard University. I will tell you, during that time period when we used to go down to the NBC4 Expo, no one was doing prostate cancer screening because they were going by the U.S. Preventative Services Task Force and saying, oh, we shouldn't be doing screening. But Howard University continued to do screening because we knew that it was the right thing to do for our patients. And now when we used to screen, I think 70 men, let's say on a weekend or during a year, we're screening over 300 people. We recently just did a screening in it was in a population of Caucasian men, and we found abnormal PSAs just on screening in about 10% of white men who never would have been screened or know about it before. That, you know, now we're going to follow up and say you need to see your urologist, you need to have a repeat test, and you need to have evaluation done. So I will say that it's so important for us to be involved in our own healthcare, because changes can be made. And like I said, the changes that were made with that now was to look at early screening in people of color and then further work up an evaluation. And I think the same thing now is going on for women with recurrent urinary tract infections, not just treating people with antibiotics. You know, if you have more than 3 urinary tract infections in a 6-month period, you should ask your doctor for a referral and for further evaluation, so that we don't see this shift again, like we see and have seen in Black men, that we'll see in Black women with detection and treatment of bladder cancer, not detecting it at a later stage than it should be detected. These cancers are not necessarily different because of a person of color, meaning that, in some cases, people of color do have a sort of worse cancer in terms of cancer cells, but it's not because they are a person of color necessarily. The prostate looks the same if I take it out of a Black person and a white person or Asian person, whatever. But what we are seeing, that over time, there have been different stressors on cells that change what's called the epigenetics of a cancer. So it may be in terms of African-American men and people of color with prostate cancer. It's not that they have any particular different type of cancer, but going back, 1600 or days of slavery, just a stress of slavery on the cancer cells, just the stress of living in the Black community and not having the proper foods and things to eat, just the stress of going out knowing that you may be shot and killed, that stress, so those epigenetic factors can cause a change in the cells and may lead to different types of different diseases that we see in people of color versus people, white people versus Black people. So the epigenetic factors are actually maybe more harmful than the genetic factors in prostate cancer, for example.
Carol Tatum, you had a question?
Thank you so much. I got on late. I just have a question. Okay, if you have an accident or somebody has an accident, and you said depends are the worst thing. I came in on the last part of the exercise. Besides going to the doctor if you have one accident or two, because depends are supposed to be terrible. What were you supposed to do again?
Well, depends are not, quote, well, in my mind, they're not, quote, terrible, but I don't want you or a person to depend on the depends. The depends is just the garment that's helping you capture the urine that you are leaking, but you shouldn't be leaking that urine. And so therefore, you need to be evaluated to find out why you are leaking that urine and not just wearing the depends. What does the depends do? The depends collects the urine, so it helps you not leaking it through your clothes and being embarrassed by that. What else does the depends do? The depends traps that urine close to your body, which can cause further irritation in the for men and women in terms of skin hygiene and breakdown of skin, things like that. So the depends is something that can be helpful, but get an evaluation first. I will say that we cannot necessarily control all urinary accidents with muscle cable exercises. I was speaking about learning how to actually activate the correct muscles and strengthen those muscles. Now, again, like any muscle activity. You have to continue to do the exercises. If you stop doing exercises, the muscle is going to get weak. So it's a continuance, but you have to know what muscles you're actually working. There are medications that can be given to help control bladder urges and urinary leakages, depending upon, again, what the cause is, say it's after prostate surgery or sphincteric problem. Sometimes there can be slings or artificial sphincters or different things that can be put on. But the thing is, if you don't know, knowledge is powerful, right? You need to know what is your particular condition that could be contributing to this, and how can you control it? There's prompted voiding times. You say, okay, I'm going to drink fluids now. I know within 2 hours I need to go to the bathroom. Don't wait 3 hours. There are people that know where every bathroom is in the shopping mall. Well, that could be helpful to know that, but that could also interfere with your quality of what your retail therapy, as I say, that you're doing while you're there. So there are ways to help manage the condition. And there are other products out there now. I'm not just speaking on Depends, or other pads and things that can be used, minimal pads, incontinence pads. And I will say sometimes we might recommend that if that's one way to help you to feel comfortable so that you can go out and enjoy your life and not have to worry about staining your clothes or anything like that. But I'm just saying, get an evaluation, make sure there's nothing else underlying that actually could be treated. If you have a urinary tract infection, you take an antibiotic, you can be cured of that. You don't need to continue to go on with that. So that would be the thing that the take-home message that I would want you to have there.
Okay. Sylvia, you had a question?
Yes. Good morning. Thank you, Dr. Coleman. Very informative. Can you, in this day and age, we're told to drink water, so much water to stay hydrated. Can you address how much water is too much where your urine is just almost clear?
Right. Okay. So drinking water. Water is something that our bodies need. They extract from other fluids, basically water. So now, and there are different types of water. There's more alkaline water, there's more acidic water, and things like that. But in general, your body needs, I was saying, you can just think of your weight divided by 20. That's how many glasses meaning a 6 to 8 ounce glass of water that you should drink a day. The urine also has a certain coloration. It should be, some people say, quote, golden yellow. Well, that depends on when you urinate in the toilet. It's going to be somewhat, diluted, right? So it may not look as golden yellow, but it shouldn't be as clear as water. You can find an old cup at home, urinate in a cup and see what that looks like, but it should not be as clear as water. If it's as clear as water, in general, that may mean that you're drinking too much water or too much fluids. And so you're diluting the urine as it should be. If you're not drinking enough, it may be darker. And then again, you might be able to smell the urine as you that. So there is a balance, like everything, on what the urine should look like in general. But it should not be as clear as water, and it should not be as dark as orange juice. And it should not be as red as tomato juice. So those are just some things to just kind of keep in mind. But there is an adequate, and you can actually determine, for yourself, how much fluid you drink. You can do your own test at home. You can drink the amount of fluid that you have. If you can, get an old bottle or a urinal, urinate in the urinal, and you can see what your input is and what your output is, and get an idea of that. And then you can see that for yourself. But again, if you have any questions, concerns, because it can be individual, especially if you've had a kidney transplant, or especially if you have heart disease and you're supposed to be on somewhat of a fluid restriction. So it's not a one size fits all, but it is something just to keep in mind.
Okay, thank you.
You're welcome.
Well, thank you very much, Dr. Coleman. Are there any other questions that you have to ask while we have Dr. Coleman to answer our questions? Well, thank you very much for a very provocative and all-encompassing presentation for us, and can't thank you enough. And Look forward to you coming back to us again to keep us informed as we approach those golden years and help us to age as gracefully as possible. Thank you
Yeah.
very much, Dr. Coleman.
Thank you all.
Wish
Thank
you
you
the
very
best.
much, Dr. Callender, for having me. And thank you, John and Pearl and John and Janice and Darryl and Dolores and Ella and Sylvia. There's a couple of Johns out there. But thank you all very much for your time. And again, if you need my help, please don't hesitate to call me. Have a great day. Thank you.